I have the honor and privilege of hosting today's round, and we have the privilege of having Ryan Sless, who is one of our PGY5. He has a major interest in sports cardiology, and he's going to talk about how and when the heart races. Please go ahead, Ryan.
All right, thank you. So I think I know most people on here, but yeah, again, my name's Ryan. I'm one of the second year cardiology residents, PGY5s. So today I'm going to talk about sports cardiology, risks, recommendations, and realities. So I have no disclosures. The objectives of the talk today are going to be to outline the effect of exercise on cardiorespiratory fitness and cardiac remodeling, to discuss an approach to differentiating athletic remodeling from pathology, to outline guideline recommendations for sport and exercise in cardiac conditions. So we know that competitive athletes and highly active people are a growing population in Canada and in the world, with more and more people signing up for marathons and triathlons on a yearly basis. We know that all of our guidelines pretty much unanimously suggest 150 minutes per week of moderate intensity exercise, both for health and with almost all cardiac conditions. And we know that exercise reduces cardiovascular events overall, but in some suggest that it may be harmful in some conditions. So it may lead to sudden cardiac death. There may be detrimental effects of excessive training. And what about its safety during underlying cardiovascular disease? So those are some of the things that I'll get into talking about today. So in sports cardiology, there's two main facets. There's patients with established cardiovascular disease. So these are patients who have underlying coronary disease, who have cardiomyopathies, who have arrhythmias, congenital heart disease, etc. And the job is to try and determine the interplay between their disease and exercise. We know that mild to moderate intensity exercise, again, this guideline directed 150 minutes per week is pretty much safe in everybody. But what about those who want to engage in more extraneous or higher intensity of exercise? And then the other facet is athletes. So athletes who desire completion of high levels of exercise, high intensity sport. What happens if they have underlying cardiovascular disease? What happens if they have cardiorespiratory symptoms associated with their sport? If they have injuries or if they have cardiac comorbidities, what are the return to sport guidelines? And then, of course, screening for cardiovascular disease, which I'm not going to talk about today because that could be a whole topic on its own, but something that would fall under this facet as well. Overall, it's a very new field. There's been more and more people gaining interest in it, but really there's not a ton of guidelines up until more recently. A lot of things are still based on expert opinion because, again, studies are lacking. But there are guidelines arising. I'm sure all of us have seen the 2020 guidelines on sports cardiology and exercise in patients with cardiovascular disease. So these come from the ESC, or the European Society of Cardiology. And then more recently, just in February of this year, the ACC and AHA put out a joint position statement on clinical considerations for sports participation for athletes with cardiovascular abnormalities. So this has been really helpful in helping to kind of create some sort of framework or guideline for individuals who want to engage in this high intensity level of exercise but have underlying cardiac comorbidities. So throughout this talk, I'm really going to highlight and define concepts of the four different domains of sports cardiology and discuss kind of clinical approach algorithms. So those will be things like differentiation of exercise-induced cardiac remodeling from cardiovascular pathology, evaluating symptomatic patients, so competitive athletes and highly active people is the acronym CAHAP, which will come up a couple times, management of those individuals with cardiovascular disease, and then again, screening, which I'm not going to talk about today. But the questions really are kind of what are the typical cardiac adaptations and over what time do these occur? Is sport cardioprotective? Is it ever cardiotoxic? And if it is cardiotoxic, is it structural? Is it electrical? Is it a combination of the two? Are all athletes vulnerable, or is it just a select few? And that's where screening comes into play. And is it safe to exercise with underlying cardiovascular disease? So, of course, the talk on kind of sports cardiology wouldn't be complete without a brief review of the hemodynamic characteristics of both static and dynamic endurance exercise. So we know that all forms of vigorous physical activity in competitive athletics involve some combination of static and dynamic exercise physiology. Static and dynamic refer to the patterns of skeletal muscle activity and their consequent changes in cardiovascular structure and function. So strength training, which is an example of static activity, is typically characterized by short and forceful skeletal muscle contractions, which really leads to intense skeletal muscle activation. And this, coupled with stimulation of mechanical and metabolic afferent signals, acutely leads to increases in systemic vascular resistance and mean arterial pressure. So our cardiovascular adaptation in order to maintain cardiac output in the face of increased afterload is to increase contractility. And this is in contrast to dynamic training, or primarily endurance training, which is characterized by repetitive rhythmic contraction and relaxation of large skeletal muscle groups, which requires increasing oxidative metabolism. And this type of dynamic activity can be quantified by the measurement of oxygen uptake. And again, the primary response here is to increase cardiac output to ensure adequate oxygen delivery to active muscle beds. And this is accomplished by increasing heart rate, augmenting stroke volume, and reductions in systemic vascular resistance. So this is a figure that comes out of Dr. Mack's lab at Mount Sinai, just showing basically the intracardiac hemodynamic effects of exercise, both light, moderate, and strenuous exercise. And we can obviously see that in the bottom left, cardiac index increases significantly with exercise. So does wedge pressure and mean PA pressure. And this will become a little bit more relevant later in the presentation. But we see that really initially there's a pretty stark increase in wedge pressure and PA pressure when exercise is started, even with low intensity exercise. And it remains relatively constant despite increasing intensity of exercise. And then how do you know what falls into this dynamic or static component of exercise? Well, both ESC and ACC have put out some figures in their papers that kind of classify what type of sport falls under which category. And it has some relevance for underlying cardiac conditions and what our guidelines or prescriptions will be. Obviously power exercise or the highly static component would be things like weightlifting, wrestling, shot put, kind of those track and field events. And then the more dynamic or endurance training, things like jogging, road cycling, triathlons, etc. So participation in extensive endurance exercise stimulates adaptive changes in cardiac structure and function, and this leads to exercise-induced cardiac remodeling. And that's influenced by a number of factors, which include ethnicity, sex, genetics, and epigenetic factors like the sporting discipline and the duration of exercise exposure. Typically, endurance exercise requires augmented cardiac output, as I talked about a couple of slides ago, and this typically leads to dilated left ventricular volumes. But the changes aren't just purely isolated to the LV. There's often changes in RV morphology, there's changes in atrial structure, and it's not just systolic changes. You also get augmented diastolic function as well. With the idea that with increasing dynamic component of exercise, typically you get more eccentric or dilating or LV and RV dilation in terms of the remodeling, when the higher proponent of static exercise leads to more concentric LVH or thickening of the walls. And so there's lots of data that demonstrates this. We know that cardiac chambers dilates progressively with increasing amounts of endurance exercise. And this is just showing that it's not just from a small amount, it continues to occur over time. So this is from a study that examined endurance athletes who were put on a training plan for a period of 12 months, and it looked at their end diastolic volume in both the LV and RV as well as wall thickness. And pretty much there's a relatively linear response that increasing the amount of time increased the amount of dilation. And so what does this mean overall for health? Well, we know that greater lifelong exercise leads to more compliant ventricles and larger stroke volumes. Again, this is another study that looked at sedentary individuals, casual exercises, and competitive exercises, and it looked to see how their wedge pressure and stroke volume were related with invasive hemodynamics. And obviously, those who are more competitive or those who engage in more high intensity endurance exercise have dilated LVs, they have bigger hearts, but they have bigger hearts at same filling pressures. And so this allows for more effective contractions. They also have more distensible compliant LVs, which give larger stroke volumes. So overall leading to theoretically improved systolic function. And again, it's not just in the systolic function, but the greater lifelong dose of exercise leads to more distensible and compliant left ventricles. This is kind of reflective of diastolic function, reflecting the LV distensibility and compliance. And so those who are more or those engaged in higher intensity exercise have these more compliant left ventricles. And of course, from the standpoint of overall mortality, we know that physical activity reduces mortality. I think this is clear. There's a dose-response relationship, both in regards to all-cause mortality, cardiovascular disease mortality, cancer mortality, and also just the incidence of cardiovascular disease and cancer on their own. And if we look at what kind of a meta-analysis of the data suggests, 150 minutes per week of moderate vigorous intensity physical activity is the current recommendation, basically by guidelines unanimously, because it leads to a pretty significant relative risk reduction in all-cause mortality. But there is still a little bit of an incremental benefit from increasing the amount of exercise. So really up to kind of 4 to 5 hours is where you continue to get those incremental benefits. But really, overall, this is just showing that yes, exercise is probably one of the most beneficial things we can do for our patients in reducing cardiovascular disease and mortality. And what about in kind of some more specific cardiovascular conditions like HCS? So there's been several studies that show that frequency of physical exertion per week is associated with a decreased relative risk of the onset of MI, with those who do more physical activity have a reduction in their relative risk, again, with more activity leading to greater reduction in their risk. So then several years ago, there was questions that were put out about whether or not intensive exercise can harm the hearts, and are the benefits of competitive endurance training in terms of cardiovascular structure and function purely beneficial, or is too much such a thing? And this was really popular a couple of years ago, but I think has kind of started to die down a little bit. But there were several studies kind of addressing what harms could there be from intensive exercise. And many of you may be familiar with this study, which was a St. Mike's-based study that looked at athletes and recreationally active people as their control group. With the athlete's heart study, they did cardiac MRIs, and it showed that focal LGE was identified in 33% of endurance athletes, but also 20% of physically active individuals. And primarily, 24% up, so almost the entirety of that 33% was at the RV hinge point. And really, this kind of begs the question of what do we make of this information, or does this matter? I mean, we see RV hinge point fibrosis quite often on cardiac MRIs, but we don't really know its association with mortality, morbidity, arrhythmias, etc. Is there really any clinical implications associated with this? And the reality is that we still don't know. But in general, expert opinion would suggest that it's of little clinical importance. But maybe this occurs because of changes that happen in the RV, and we know that changes in the RV happen acutely with exercise. So this is an example of a couple different studies here that looked at RV function and dilation acutely after high intensity exercise, and we do see that there's significant impact of the RV. So in the top left is individuals who underwent a long endurance race, basically a marathon, and it looked at individuals' right ventricular ejection fraction from several different planes at baseline, immediately after the race, and 2 weeks post. Same thing down here, looking at RVEF in several different races, and basically we can see across the board that immediately post race there is a pretty significant drop in RV ejection fraction, but within 2 weeks it almost recovers completely. And similarly, if we look at the end diastolic and end systolic volumes, immediately post-race, not really a significant change in regards to the LV, but the RVs do dilate. So acutely, the RV dilates, RV ejection fraction drops, but this does fully recover within a period of 1 to 2 weeks. And it's perhaps this constant change in individuals who are consistently engaging in high-intensity exercise that leads to maybe this hinge point fibrosis that we see in the RV. But again, does it really matter? And then this is just that figure that I brought up earlier, and just to kind of loop back to it to kind of explain why potentially we may see elevations or these changes in the RV immediately post-exercise, specifically drawing your attention to the mean PA pressure. There's a pretty significant increase in mean PA pressure associated with exercise, which means that there is a significant RV afterload. And in order to meet oxygen demands and keep up cardiac output, the right ventricle has to pump against this higher pressure system. And so this is probably what contributes at least some of the RV dysfunction and dilation acutely with exercise. So in summary, in terms of the benefits and risks of exercise, overall, we've demonstrated that there's a monotonic relationship between aerobic exercise and positive health outcomes. And this comes from decades and decades of research that show this. We know that intensive exercise is foundational in cardiac rehab literature for patients with all spectrums of cardiac conditions. Now, this is primary for non-athletic patients, but likely can be attributed to athletic patients as well. And there's some evidence that exercise may trigger life-threatening arrhythmias or increase risk of sudden cardiac death. However, an important caveat here is that the majority of sudden cardiac death in the population still occurs at rest. And I'll get into some more specific cardiac conditions and where this may be relevant in a bit. But even in individuals who have underlying coronary disease or underlying cardiovascular disease, this comes from a study of individuals who have an elevated calcium score, and it stratifies them based on those who are highly fit and those who are not. Those who are very fit, who are able to achieve over 10 METs in their exercise test, had a significant relative risk reduction in cardiovascular events compared to those who weren't fit. And this is in individuals who have the same level of quote unquote risk based on their coronary calcification score. So I brought up that circulation paper from Ben Levine a couple slides ago, talking about kind of a summary of can intensive exercise harm the hearts, and these are really the summary from that paper and take home message. Um, it's that athletes have large compliant hearts that generate a large stroke volume during exercise and compliant arteries with large vasodilatory capacity. The heart of a senior athlete with a lifelong pattern of intensive training is very compliant and equivalent to that of healthy young 30-year-olds. Acutely, there can be changes that cause fatigue of cardiac muscle, primarily in the right ventricle, but this recovers quickly. The older athlete is probably at increased risk for atrial fibrillation, again, probably because of long-term dilation of chambers, primarily in the left atrium. But there's really minimal evidence that intense training really accentuates cardiac fibrosis, and the amount of evidence that there is weak. Also, there was some question about whether or not high intensity training in the presence of advanced atherosclerosis is dangerous. And I think common sense would say if there is the presence of ischemia, then potentially it is, and this needs to be dealt with. But again, I'll talk about this more in a couple slides. So moving on a little bit from the benefits and the risks of exercise, what happens in clinical practice and what happens when we see these patients in practice? So there's a case of kind of just a common referral that I think most people will have encountered, and we can talk through a little bit of a diagnostic approach to it. So a 30-year-old who is referred for air hunger has a past medical history basically just for asthma. On Pantelok and Symbicort puffers, they have no significant other family history. They have no significant relevant alcohol or drug history. He's a marathon runner, training for a triathlon, does 1 to 2 hours per day of multimodal sport. Doesn't have any exertional symptoms, but have symptoms of air hunger. So of course he gets an ECG and an echo, and the echo shows a moderately dilated left ventricle, EDVI of 95 milliliters per meter squared, and a low normal systolic function, so 52%. Again, not crazy, but for a 30-year-old, they shouldn't have a low EF, and the question of why is their ventricle so dilated? RV is normal, and left atrium is mildly dilated as well. So this is a nice figure that comes from a paper from 2020 by Miller that shows basically the differential in athletes for these different findings that we'll see quite commonly. And for this patient specifically, if we draw our attention to the middle row of the dilated LV chamber. So again, the key differential, this is really the same for any patient that we would encounter that has a dilated LV or mildly reduced LV function. So idiopathic dilated cardiomyopathies, toxins, myocarditis, secondary to tachyarrhythmias, valvular heart disease, etc. But some of the key factors that may be in keeping with exercise-induced cardiac remodeling as opposed to pathologic changes would be the history of pretty significant exercise or sport background, the lack of subjective symptoms with exercise, no relevant family history, no history of prior illnesses that would be suggestive of myocarditis, et cetera, and no history of substance abuse. And then when we look at the imaging findings that would be consistent, well, typically this includes if there's concomitant RV dilation, if there's low normal systolic function, we typically look to see at the left and right atria if they're mildly dilated as well, and they should have no significant valvular disease. So this outlines a simple algorithm that kind of is to aid in assessing active individuals with LV dilation or LVEF less than 55%. On the left are changes that you would support physiological adaptation or quote unquote the athlete's heart. And on the right, those that suggest pathologic remodeling. So those who have a negative NT-proBNP favors physiology or athletic remodeling. No significant abnormal changes on the ECG, like a left bundle, ventricular ectopy, T-wave inversions, et cetera, that would favor more pathologic type appearances. No NSVT on Holter, and then the exercise echo. So stress echo is pretty key here to look to see if there's augmentation with ejection fraction with exercise and no obvious regional wall motion abnormalities, as this can help really differentiate whether or not these patients have more physiologic versus pathologic adaptations. So if we take our patient we were talking about here, this is his echo. Baseline here, EF was read at around 55%, so slightly higher at the time of the stress echo. But we can see that with stress, very significant augmentation in LV function, definitely greater than 11%. So was able to significantly augment their left ventricle with exercise. And this favors physiologic adaptation or the athlete's heart. And this is in comparison to another individual here who had a low normal ejection fraction at rest, went on to have a stress echo. And the stress echo picture was be in the top right-hand corner here. Sorry, I should have mentioned that. But we see with exercise, there's not really a significant augmentation in their LV function that plays relatively static. So this is an individual that you might have expected at baseline based on their exercise history would have had an athlete's heart. But when we get the stress echo, we see that there is no augmentation in LV function with exercise. And so perhaps we're actually dealing with some sort of dilated cardiomyopathy that needs to be further investigated. So just to summarize this case, the 30-year-old, again, they had an exercise stress echo that showed pretty significant augmentation in their LV function, a negative ECG, and they returned to baseline post-stress. And also of note here, very physically fit, achieving 20 METs on the accelerated Bruce protocol. So this is quite in keeping with an athlete's heart. And just to summarize some other features that are in keeping with athlete's heart, they may have increased wall thickness. 12 millimeters typically is perceived as normal. Anywhere between 13 and 15 is a bit of a gray zone, so could be normal for an athlete, but could be abnormal. And greater than 15 millimeters, you need to further investigate. Athletes may have decreased LV function. Many of them have between 50 and 55%, as I demonstrated with the last case. Some of them do have an EF between 45 and 50%, and it's a bit of a gray zone. But less than 45% definitely should prompt further investigation. And the key here, obviously, is that it should augment with stress. So they should be able to increase their cardiac output and attempt to meet the oxidative demands of aerobic exercise. Athletes may also have greater RV remodeling. In fact, there's been some data that suggests that athletes actually, in terms of their RV, might meet a lot of ARVC task force criteria for ARVC just based on the remodeling of the RV. So we really need to be careful when looking at individuals and looking to see if there's multi-chamber involvement and investigating appropriately. But this RV remodeling probably occurs because it's a thin-walled structure. It has a greater relative increase in pulmonary pressures with exercise. As I showed earlier, the RV has to put up with higher RV afterload as a result of these increase in mean PA pressures. And then athletes often have dilated atria. And so an important thing to keep in mind as well is typically you would see multi-chamber enlargement in athletes. So when individuals have multiple of these, it's potentially more consistent with an athlete's heart. And then just to touch on briefly, HFpEF and exercise deficiency. Well, there's a study or a paper from 2022 in JACC that basically described the spectrum of physical activity. And we know that athletes have bigger hearts, more compliant left ventricles, they have high cardiovascular respiratory fitness. And this probably leads to quite a low HFpEF risk. And they postulate that potentially HFpEF is a syndrome of exercise deficiency where you end up getting a small, less compliant heart, and this increases your risk of HFpEF. So again, when evaluating an athlete's heart compared to other pathologic conditions, there's multiple things that we need to keep in mind. So again, I mentioned already LVH. So kind of that 13 to 15 millimeter is kind of our gray zone between athlete's heart and something like HCM. But if it significantly increased, we definitely should investigate for other conditions like HCM. And important things to consider would be if there's focal areas of thickness in the wall that may be more in keeping with an HCM as opposed to if it's more uniform. In terms of dilated cardiomyopathies, again, we talked about dilated chambers when they may be considered pathologic versus physiologic. But if there's significant drops in LV function, specifically below 45%, or there's failure to augment with stress, then dilated cardiomyopathy should be further investigated. As I mentioned, in terms of ARVC, a lot of athletes meet task force criteria for their RV. So we need to kind of be very careful in investigating appropriately because, again, there are significant changes that occur with exercise in regards to the RV function. And then also LV non-compaction. Athletes can have quite hypertrabeculated LVs, and there has been data to show that when athletes stop training or detrain, these trabeculae actually resolve. So some of these findings may just be related to athletes as well. So if we find individuals that actually have pathologic adaptations and we're wondering what is safe for them and what level of activity is safe, that's where some of the new guidelines come into play. So high intensity exercise may be considered in those who have dilated cardiomyopathy. So we'll talk about this a little bit. So sudden cardiac arrest risk does increase with lower ejection fraction, with the presence of symptoms and with higher scar burden. And there's some specific mutations of dilated cardiomyopathy that may increase the risk of arrhythmias and sudden cardiac death. And these would be our LMNA, desmoplakin, and our FLNC mutations specifically. The effect of vigorous exercise on progression of dilated cardiomyopathy and risk of sudden cardiac arrest are not known, but there is some evidence to say that higher cumulative lifetime exercise may be associated with reduced LV function in the LMNA dilated cardiomyopathy and potentially also in desmoplastic cardiomyopathy as well. Really, in those who have LMNA, when the LVEF is less than 40%, the risks of competitive sports participation significantly outweigh the benefits. And when we talk about competitive sports participation, we're really talking about any level of high intensity exercise, whether it be recreational or competitive. And so what do the guidelines say in regards to dilated cardiomyopathy? Well, really low to moderate intensity exercise can be considered in all, regardless of the ejection fraction, in the absence of limiting symptoms or exercise-induced ventricular arrhythmias. And this low to moderate intensity exercise really is the 150 minutes per week that's unanimously recommended in the guidelines. They also say in this point here that participation in high intensity exercise or competitive sport may be considered in those who do not have high risk features. So those who have an EF between 45 and 50%, who have only mildly reduced LV function, who do not have complex arrhythmias on ambulatory or monitoring or exercise testing, no LGE on CMR, and are able to increase their LVEF with stress, and who don't have these high-risk genotypes that I just discussed. And then they also say that those who have high-risk features should be restricted. And in these individuals, the risks of high-intensity exercise or competitive sports may outweigh the benefits. And those would be in individuals who EF is less than 45%, they have complex ventricular ectopy, they have extensive LGE on their MRI, or they have high-risk phenotypes. And then importantly, one more key thing that came out in the 2025 guidelines is that they do say that no restriction should be placed on any individuals who are genotype positive but phenotype negative. And this is going to become of increasing importance as genetic testing becomes more normal and we start to find people who have either variants of significance or insignificance. But in those who do not demonstrate a phenotype of the pathology, they say that competitive sports participation is reasonable, with the caveat being that they should have frequent assessment to make sure that there's not any progression of the condition. So moving on from dilated cardiomyopathy, if we look at hypertrophic cardiomyopathy, and this is where the guidelines and the data have really changed over the years. So there's data that suggests that hypertrophic cardiomyopathy accounts for sports-related sudden cardiac death in only about 6 to 10% of individuals in the general population. So a study in Ontario that looked at 7 million person years follow-up, there was 53 sudden cardiac deaths that were attributable to HCM. And of those 53 that were attributable to HCM, only 17% of those are related to exercise, which puts the risk at about 0.064 per thousand. In Ontario, hypertrophic cardiomyopathy has been the cause of sudden cardiac arrest during sports in only in about 12.5% of competitive athletes. So that's individuals who had a sudden cardiac arrest, only about 12.5% of them was a result of HCM. And there was a paper that estimated the risk of sudden cardiac death for athletes with HCM competing in sport at about 0.03 to 0.1% per year. And putting that in perspective, military recruits who are known to have HCM have about a 0.05% risk of sudden death or sudden cardiac arrest. So really, the athletes don't have that much of an increased risk. Realistically, overall, HCM-related sudden cardiac death is extremely rare, and it only contributes to a small proportion of sudden cardiac death in athletes. I think it's just become so popular, or really a hot topic, because it's something that's actually identifiable, whereas a lot of sudden cardiac arrests, there's actually no clear cause or trigger identified. So again, what do the guidelines say? The guidelines have really shifted over the years as these studies have emerged. Previously, international guidelines recommended against participation by patients with HCM in sport activities, except for low intensity sport, irrespective of whether they had symptoms or not, if they had LVOT obstruction or not, or if they had other high risk features. The guidelines have liberalized a little bit now, and they suggest that participation in high intensity recreational or moderate to high intensity competitive sport may be reasonable for those with HCM. Of course, they recommend a comprehensive evaluation prior to engagement in high intensity exercise. And they suggest risk stratifying based on really just general risk factors for sudden cardiac death. So some of these markers for increased risk include symptoms, history of cardiac arrest, history of unexplained syncope, an elevated LVOT gradient at rest, abnormal blood pressure response to exercise, or obviously exercise-induced arrhythmias. And importantly, yet again, there's no restrictions placed on those who are genotype positive and phenotype negative in the new 2025 AHA guidelines. Again, with the caveat being that patients should be followed over time to make sure that they don't develop the phenotype, which again is not really different than what you would be doing anyway. So another common condition that's brought up a lot in regards to exercise is the arrhythmogenic cardiomyopathies, like ARVC. And in these individuals, genotype is really important as it's a significant risk factor for sudden cardiac arrest. So there's a significant amount of evidence to suggest that endurance-based sports heightens the risk of sudden cardiac arrest and disease acceleration in those specifically with the PKP2-mediated ARVC. But this is not really well established for other genotypes. It's important to carefully avoid misdiagnosis, i.e., wrongfully assume someone has exercise-induced, or wrongfully assume that exercise-induced RV remodeling is ARVC. As I mentioned, a lot of these athletes can have significant changes in their RV with increasing sport participation. And there's no evidence for heightened sudden cardiac arrest in those who are genotype positive or phenotype negative. However, we do know that vigorous exercise may increase the risk of phenotypic conversion in the PKP2 and the TMEM43 arrhythmogenic cardiomyopathies. So there is a recommendation for close surveillance to detect early signs of phenotype development in those who do have these mutations, even if they are phenotype negative. So again, looking at the guidelines, low to moderate intensity, 150 minutes per week. Again, relatively safe for anyone, unanimously recommended in all the guidelines. But participation in more intense or more strenuous exercise is more likely to be limited, or the risks are more likely to outweigh the benefits in individuals with these abnormal gene mutations such as the PKP2, and of course in any individual who have these higher risk factors, which would be unexplained syncope, history of cardiac arrest, significant amount of PVCs, or exercise-induced complex ventricular arrhythmias. And as I mentioned on the last slide, they still do say in the new guidelines that those that are genotype positive but phenotype negative, even for one of the known genetic mutations that it's at higher risk, like the PKP2, that they still can engage in sport if they're phenotype negative, but they should have close follow-up to make sure that they don't develop the condition. And then if they start to develop the condition, potentially have more restrictions thereafter. And they do also say that individuals who have the non-PKP2 cardiomyopathy can consider competitive sports participation after a comprehensive assessment, but understanding that we do not fully know whether or not exercise hastens disease progression in the non-PKP2 genotype as well. So another common condition that we see quite a bit is myocarditis. So what do the guidelines say for that? I mean, we know that sudden cardiac death can occur with vigorous exercise in the setting of active inflammation that can trigger malignant ventricular arrhythmias. We know that impaired LV function and high amounts of LGE on cardiac MRI can predict poor outcomes. We know that there is previous expert data that has recommended return to play after 3 to 6 months, but new data in the COVID area suggests that inflammation may resolve at 4 to 6 weeks, and perhaps earlier return to sport is reasonable. And so I'll just highlight exactly some of those points here based on the 2025 guidelines. First off is that athletes should abstain from involvement in competitive sport or high intensity exercise until symptoms and inflammation/edema have resolved. They can return to sport or completion of high intensity exercise if the following criteria are met. So if they had 3 months without symptoms, if they previously had reduced LV function, but their LV function has completely returned to the normal range, if there's been resolution of inflammation either by repeat CMR or by serum biomarkers more realistically, and if there's no clinically relevant arrhythmias or complex arrhythmias on ambulatory monitoring or ECG testing. And then again, this earlier return to sport at 4 to 6 weeks may be reasonable in individuals who never had reduced LV functions, where LV function was always preserved, and if they have revolution of their inflammation as measured by serum biomarkers and have no clinically relevant arrhythmias. What about in coronary disease? Well, we know that underlying coronary disease leading to plaque rupture or demand ischemia, really any cause of ischemia, is the most common cause of sudden cardiac arrest in masters athletes. So what do the guidelines suggest here? Really, it's just a common sense approach based on what anybody else, or based on how you would be treating any individual who's not an athlete. So low risk asymptomatic athletes do not need to undergo additional risk stratification. Those who are intermediate to high risk require lifestyle modification, guideline-based medical therapy, potentially non-invasive risk stratification. And if the non-invasive risk testing suggests inducible ischemia, then they should undergo angiography and have these high-risk lesions appropriately adjusted. Really, you want to prevent anyone from exercising with ongoing ischemia, as obviously this could be a major cause or trigger for ventricular arrhythmias. The main difference in the athletic population is that if you do identify someone who has a high-risk lesion, we should recommend that the risks of exercise probably outweigh the benefits until these high-risk lesions are dealt with or they have complete revascularization. What about the aortas? So it's quite a common question that we get athletes that have marked increases in their aortic sizes or aortic dilatation. And this is a study from 2020 that actually shows that probably aortic dilatation in athletes is normal. And so they looked at individuals, both runners and rowers, and they measured the aorta in several different locations, both men and women. And they found that 45% of male rowers had at least one aortic dimension greater than 40 millimeters, and 36% of women had a dimension greater than 34 millimeters. And they basically stated, and this has come up a couple times in more recent guidelines, that quote unquote normal values for athletes would be 42 millimeters in males and 40 millimeters in females for any of their aortic dimensions. So again, if we go to what do the guidelines say for how should we counsel people on exercise if they have these dilations in their aorta, and the 2020 ESC guidelines say that high intensity exercise is permissible in any individual if their aortic size is under 40 millimeters. If it's between 40 and 45, they suggest avoiding high and very high intensity exercise, contact, and power sports. And if it's greater than 45, they state that only low intensity exercise is advised. And of course, those that are high risk that meet surgical indications should avoid sport until they have their aorta fixed surgically. And the 2025 guidelines are slightly more liberal. They use these new normative values of 42 millimeters. And they say for individuals up to 42 millimeters, and even those with 43 or 43 millimeter sized aortas, competitive sport or high intensity exercise is still reasonable. Again, after a shared decision-making conversation with a consultant. But they again say that it's at dimensions greater than 45 millimeters, the risks may start to outweigh the benefits in the very high intensity exercise. So caution should be had there. And again, important is follow up to see how these are changing over time. So I've talked a lot about different levels of intensity of exercise. And I said that in general, low to moderate intensity exercise almost always seems safe. But what exactly is low to moderate? So the topic of exercise intensity, it's always a little bit controversial. With exercise testing or CPET, you can get a pretty clear idea as to what level people are training at using their VO2, their heart rate reserve, or their heart rate max. But many studies suggest that using ventilatory or anaerobic threshold is a superior measurement, and I'll talk about what that are a little bit. So if we look at the training zone here, so just looking at training zones, if we look at low to moderate intensity exercise, those are primarily aerobic. So these are levels that you can pretty much train at and go for pretty much as long as you want, walking at a comfortable pace where you're able to carry a conversation, running the same where you're able to carry a conversation, etc. You can almost go forever. But when you switch between what they say here is moderate and high intensity is when you start to develop some lactate. And that change between the moderate and high intensity, where we start producing lactate, that's our anaerobic threshold or our first anaerobic threshold. Before that, for those that are familiar with exercise training zones, would be our zone 2 training. After that would be kind of our zone 3. So we've started making lactate, but our body is still able to clear the lactate. So we're working pretty hard, but we're not working too hard. At this level, you can probably still keep up for a good period of time, but you're not able to keep up this level of exercise forever. And then the point in which we go from producing lactate, but then producing lactate faster than we can clear it and starting to work anaerobically is our second anaerobic threshold. So that transition between high intensity and very high intensity exercise. And we can imagine that in any of these states where we're producing lactate, our blood probably becomes slightly more acidic. We have to work on buffering it. There might be a signal that this may be an area where there's higher risk of developing complications or arrhythmias. And so these thresholds can be used and are used in exercise prescription as well. So how do we measure the lactate threshold? Just very briefly using CPET. We know that metabolic acidosis from the production of lactate starts to increase our VCO2, again, being converted to carbon dioxide, and VCO2 then rises disproportionately to VO2. And that's where we get our anaerobic threshold when looking at the slope method there. So when we see a change in slope of our VCO2 over VO2, and we also notice that there's a change in the ventilation per VO2 slope, because again, as VCO2 increases, our ventilation starts to increase. And that's first anaerobic threshold. And you can use really either of these two methods, but the slope method is known as the gold standard. And as I mentioned, there's been several studies that suggest tailored exercise prescription using anaerobic threshold may be beneficial to individuals as opposed to just using their heart rate, which is commonly done in a lot of cardiac rehab practice. But really, this study took individuals, put them on a CPET, measured their anaerobic threshold, and used values above their anaerobic threshold to recommend their training zones as opposed to just using a heart rate reserve. And the bottom figure here is individuals who used the threshold-based model for tailored exercise, and they all had much significant improvement in their VO2 in compared to traditional exercise prescription or just using their heart rate reserve. And again, as I mentioned, this can be used in pathology as well, because once we start to produce lactate and once we're working a little bit more anaerobically, this is potentially an area in which we are more likely to trigger ventricular arrhythmias, because again, lactate production, starting to develop a bit of a metabolic acidosis, needing to buffer, may put us at higher risk of developing arrhythmias, and using our anaerobic threshold to determine levels of safety in individuals who have underlying cardiac comorbidities is becoming more popular in kind of the sports cardiology world. So we're almost done here, but in conclusion, exercise is beneficial to health and mortality with a dose-related response. I think this has been shown many, many times and over the course of decades. There are a very small proportion of individuals who are at increased risk for sudden cardiac death with exercise and should be restricted. So these are individuals who have ARVC, potentially the LMNA or DSP mutations and dilated cardiomyopathy. But really restricting exercise to reduce risk in others has no evidence and is likely not beneficial. And in general, maybe low to moderate intensity aerobic exercise is always safe and recommended. But when in doubt, recommendations are to refer to a dedicated sports cardiology clinic. And the role of that clinic is to evaluate risk, because again, guidelines don't cover everything. To use exercise prescription based on CPET data, determining of anaerobic thresholds, and really a shared decision-making process. If any of you have had athletes in your practice before, really training or exercise is incredibly important to them. And it's really not our place to restrict them, but to inform them as to when we think the risks of what they're doing outweigh the benefits. And so everybody here probably knows about it because we have the clinic at St. Mike's, but we have the sports cardiology clinic. We have the referral form on the intranet. And just to finish off, just an example of cases of things that are dealt with in the sports clinic. This is an example of a 60-year-old gentleman who's post-STEMI, occluded LAD with 1 PCI and an EF of 40%, started on good medical therapy and referred to cardiac rehab. His CPET at cardiac rehab, he had frequent PVCs and a short run of NSVT during exercise. Several repeat Holter monitors demonstrated frequent runs of NSVT, and he was really, really keen on still having exercising to relatively high intensity. He was a cyclist. And the thing with a lot of these athletes is if they're able to, they want to push themselves as hard as they can. And it's not really a common thing that we encounter, because most individuals who do have such significant amounts of scar or drop in their EF are not actually able to achieve such high levels of exercise, but there are a few that are. So he went on to have a CMR to kind of quantify his risk. He had greater than 75% wall thickness of scar, high intensity LGE, fatty metaplasia, and a low EF. So really, really a high risk picture here. And on his CPET, he also had significant factors that would make him, that would be suggestive of poor outcomes. So he had 4-beat run of VT, he had some ventricular ectopy. And so as a result of all of this, his recommendations were that he should not get his heart rate above 125. This is where he started to develop the complex arrhythmias, but also where his anaerobic threshold is. So this is basically that he could only do zone 2 or less training, or relatively low to moderate intensity of exercise. But this patient had strong desires to continue exercising. So there was multiple different questions that were brought up and discussed by the group, whether or not an EP study would be beneficial, whether or not putting in an ICD would be beneficial, just as a fail-safe in case he were to continue to exercise, but had significant amounts of arrhythmias. But this is just kind of an example of cases that are discussed in the sports cardiology clinic. Obviously not common things that we see every day, difficult to deal with because there's not a significant amount of evidence associated. A lot of it is just expert opinion. But again, it really comes down to a shared decision-making model with the patients, and providing them with as much information as they can, as much as we can, to inform them of whatever benefits or risks there may be and allowing them to make the decisions. So with that, thank you very much. And I'm happy to take any questions.
Ryan, maybe I'll kick off. Fantastic presentation. I want to go back to the case that you started with and some of the potential distinguishing features as it relates to so-called athlete's heart relative to some of the cardiomyopathies. And just to get you to think again, thanks. This is perfect. When if I recall for the case at the beginning. The EF was modestly kind of low end of normal, but there was dilatation of the LV. And so, how often, on that first glance, before you look at exercise ability to improve, the LV function, for example, et cetera. But how often, because you mentioned in a couple subsequent slides, typically, if I got this right, you see some hypertrophy, but not necessarily dilatation. So how common is dilatation in the absence of, let's say, concentric LVH in the setting of so-called athlete's heart?
Right. I think that in terms of endurance exercise training, obviously there's a difference between those who do endurance or aerobic exercise and
There.
more strength type training. But in endurance exercise training, it's quite common to see dilation of the LV, really the eccentric hypertrophy as opposed to concentric and increasing in the wall thickness. So I do think it's something that we see quite a bit in terms of the dilation of the LV. And I think it's more prominent when looking at an athlete's heart in someone who's younger. So in a 30-year-old, maybe young 40-year-old, where you're seeing the dilated LV, that's where you may question it a little bit more. I think in individuals that are in their 50s and 60s, it may be something that we don't actually think about as often because we're like, oh, okay, they're in their 50s and 60s. Maybe they've had hypertension for a lot of their lives. Like maybe they have reasons for having a mildly dilated LV as opposed to it all being related to exercise. But
Okay.
certainly in which we should be considering, of course, like we should be getting a better sense of what their exercise history is to try and understand the reasons for the dilation. But in younger individuals, especially, I think we need to kind of keep in mind what the underlying cause may be so as to not miss per se something more sinister. But yeah, I'd say that there's quite a big proportion of people that do have dilation and not totally increases in their hypertrophy or wall thickness.
Gotcha. Again, depending on the type of an endurance athlete, as you say, relative to
Yeah,
somebody who's doing, weightlifting or that type of approach, which is, I think, the earlier conception of so-called athlete's heart. But I guess what I'm taking away from this is that athlete's heart may be quite different depending on what type of an athlete the individual is.
exactly. Yeah.
Gotcha. Thank you. Other comments, questions for Ryan?
I know Dr. Chow had to step out because his flight probably took
Yeah.
off. So, but if there's any other questions, I'm happy to try and answer them now.
Brian, maybe I'll ask, we have obviously great expertise, as you've ni nicely outlined, locally in a big urban center or series of centers in a big urban city like Toronto or Vancouver or Montreal. But for, community-based practitioners, including on the primary care side, who might, not have as easy access to referral. What would be sort of the ABCs here? I'm assuming an echocardiogram in an individual would be the starting point. But what sort of advice would you give to somebody who's a little farther flung from an urban center and tapping into expertise in terms of the sort of initial steps of evaluation of a patient or a person?
Mm-hmm. Yeah, no, it's a great question. And I think it varies a lot depending. I mean, there's a lot of different factors that are involved, whether or not there's underlying cardiac disease or whether or not it's someone that just has, per se, this finding of a dilated LV. And we're wondering whether or not it's an athlete's heart. But from a primary care standpoint, you're asking probably echo, get a sense of what their underlying LV function looks like. If it's mildly reduced and dilated, then a stress echo to see if it augments properly would probably be just the initial stage, and then referral to a cardiology standpoint. From a community cardiologist, I think definitely it's very difficult without having kind of a major urban center to have a lot of those resources. But I think it's really helpful that there's new guidelines that are emerging and there's a place that we can turn to. So not just 2020, but now we have new American guidelines from 2025. So just getting a sense from the newer guidelines of, not, I think there's been from history, kind of a suggestion that exercise can be bad for people with significant heart disease. And I think we want to move away from the fact that not restricting patients. And so it would be to generally allowing exercise is safe and looking to see at the guidelines to see if there's any significant recommendations for risks in the population or the patients that you have in front of you. But really just using the guidelines as opposed to just kind of restricting everybody, because I don't think we get anywhere and we lose all of the benefits associated with exercise if we just restrict everybody.
Yeah, and you made that point nicely during
Mm-hmm.
your presentation as well. Thank you. That's good.